Thank you. From my earlier presentation today, you probably got a lot of negativity, I think, about what some of those problems were. I'm really excited to be back to kind of talk a little bit about what I think could happen to help change some things in Tennessee that could help address this issue and many other issues around access to treatment. But having heard the panel, I also wanted to comment on a few things that were presented as well. What we can learn from other states is incredible. We can all learn from each other every day, but these presentations were great. I think what Katie said in particular about, stealing shamelessly from other programs is something that we need to take a more proactive approach about too. I know that there is a Middle Tennessee NAS collaborative, for example, that we contacted. I believe it was a program in British Columbia, a hospital, about their NAS protocol, and we were allowed to use it here in Middle Tennessee, and we've stolen it and with credit. There's also other things that we've done around that, and people will work collaboratively when you reach out. I think harm reduction, for example, is something that Tennessee definitely needs to consider. I do have a little bit of an anecdote, however. TANIS was part of a collaborative that proposed and worked on a 911 bill, we called it here in Tennessee. It was passed last session, where if you call 911 and you're at risk of overdose, or if someone you're with is at risk of overdose, you can call the police without fear of prosecution. It was passed, like I said, but I want you to know that as we shop this around, one of the reactions of one of the state legislators we talked to is, why would we help those people? They just need to die. So when we talk about harm reduction, we're really talking about dealing with a mentality that really goes beyond blaming and shaming, and that there is more to it. And I think we have a lot of work to do in Tennessee, but I would be encouraged to try to bring that forward. That said, I do have some upbeat points to share as well. I have a provider here in the audience from Grace House in Memphis, Charlotte, who pointed out to me that after my talk, rightfully so, that when we talk about some of the bed issues that I talked about in here, that yes, there is a shortage of methadone treatment programs. Yes, there is a shortage of Suboxone, Subutex, buprenorphine providers. Yes, there is a shortage of actual beds. But if we could move people into some of those methadone and Subutex programs, some of these pregnant women in particular, we would have potentially adequate residential treatment. But we don't have enough access to all that entire cadre of services. I think it's also important for me to point out that of the three providers who presented with me this morning, one, Vanderbilt, certainly has some inpatient and residential capacity. The MIST program, I hope you picked up, is entirely outpatient. Hi, Michelle. Is entirely outpatient. They work with a hospital during the delivery for that mother, but the program itself is outpatient. Renewal House here in Nashville talks about their program being a residential type program, and they do operate as such, but let me point out something that is a potential that we could actually work on. Renewal House basically took a HUD-funded resident housing program and coupled that with an intensive outpatient treatment program to make what looks like a residential treatment. It operates as such, but it is not licensed as such, because Tennessee does not have a family residential program license. Residential program licenses in Tennessee are focused on the prescribed patient being in treatment. There's no capacity to include a family in care in current residential treatment standards. So Renewal House, and there's several other programs in the state, have basically taken the existing licensure rules and figured out how to blend them together to make the program work. But we don't really have a family residential treatment component in Tennessee that is fundable, that a managed care company could actually contract with, and a set of standards that we could actually work with. Now, I will say that family residential treatment certainly needs more discussion, because being able to bring a whole family into treatment is complicated. And you have to provide school-based services, you have to provide daycare, you have to do trauma-informed care, there's a whole list of other things. I would not just want to say it's a simple solution. But there are 10 other states I've been able to find that have family residential care of various varieties around the country, models worth taking a look at, and I think models that would be very effective, because one of the things we know that prevents women from seeking treatment is the fact that they have to leave their families. If you have to leave your new baby or your children or your husband or your parents, and you are the caretaker, you're not going to go to treatment as easily as if you had access to a program that can wrap those services around you. Now, not everybody needs residential treatment, but there are things like the NAS Collaborative that I just talked about. There are things like the MISS program where that kind of treatment can follow women into their homes. We need more support of programs like that where that could be integrated between medical and behavioral health providers in a way that would support the family remaining at home, if that's an option for that family. Because we need to actually free up those residential beds for people who actually need residential beds, I would say. I also talked this morning about the fact that TADIS runs a hotline, a 24/7 hotline for people who need treatment referrals. And I talked about women who call, who are pregnant and need access to treatment. Yes, they are supposed to be at the front of the line. I think it would be great if we came up with a system where if that woman called, I could have somebody I could call at the state, the provider, whatever, that said, I've got a woman, she needs access to treatment today. Where can I get her in? Where can we make a bed? Where can we figure something out? And even if it's an in-home services approach, before we can actually access a bed, let's figure out a way to wrap some services around that woman so she doesn't get lost in the system before a residential bed is actually available, if that's what's appropriate for that woman. I also think that there is a protocol, a best practices protocol that the Department of Mental Health and Substance Abuse Services has published. It's actually available on their website. It's a very extensive protocol. I give them great credit for writing it. I will say I actually contributed to it, so I'm one of the authors. But there is nowhere in that protocol that provides an evidence-based practice or protocol of any kind for pregnant drug-using women. There is one for medication-assisted treatment. There's one for all kinds of other treatment levels of care, but there are no standards in this state for pregnant drug-using women access to addiction treatment. Now, I will say to their credit that that's been pointed out to the department recently and have agreed to take a look at adding such a protocol. But without such a protocol, providers are really left hanging. It's like, what kind of service is the best practice in the state of Tennessee? What kind of program can I endorse? What will a managed care company pay for even? How can I open my doors and expand capacity if I don't have a treatment protocol to kind of hang my hat on and say, this is what's needed. This is the standard of care that I need to provide. And we really don't have one right now in the state of Tennessee. One of the things I do want to briefly talk about before I get off MAT is it's been said that Medicaid will not pay for methadone treatment, and at one point it was said opioid treatment. But let me be clear, TennCare does pay for Suboxone buprenorphine treatment for pregnant drug-using women. TennCare. They do not pay for methadone treatment, so there is a distinction. Methadone treatment in the state of Tennessee is a cash-only business. The 19 treatment programs that exist around the state of Tennessee are cash-only businesses. And every single one of them is a for-profit entity. The last point I want to make is around parity. A lot was made roughly 5 years ago when Congress passed parity legislation so that treatment services for physical health conditions would be similar under insurance plans to those provided for behavioral health conditions. So many of you probably have plans, and let's say that if you go to your PCP, there's pretty much no limit on wellness care to go to your PCP and make sure you're okay, or some other kinds of benefits. if you went to a behavioral health provider, there might be a 30-visit limit, and you had to have a copay, and da-da-da-da. So you couldn't go get an assessment even at a behavioral health provider. It had a completely different set of standards for how you access care. The parity law was supposed to eliminate those discrepancies so that accessing physical health care was basically the same as you access behavioral health care. And those benefit parameters are just one of the things that the parity law dealt with. It dealt with how you authorize care. It dealt with having an adequate provider network for both physical health and behavioral health. There's lots of things that go into the parity law. But the standards from CMS to actually enact the parity law for private health insurance plans actually came out this past spring. And let me remind you, I said that this bill was passed 5 years ago. So the standards for private health insurance plans that they need to follow in order to be able to implement parity came out this spring. The standards for Medicaid and Medicare programs to be able to enact parity, those standards were put out in draft form this past spring and have not been implemented or enacted. So both Medicaid and Medicare programs currently do not have parity regulations that they have to follow. Okay? Parity would go a long way to making sure that healthcare access was as broadly accessible to anyone, certainly pregnant women included, as it needs to be across all the United States. But let me also point out an important distinction right now for Medicare programs. Many of our women that we're talking about here today are not necessarily Medicare recipients, but a few are. And Medicare currently only provides a hospital-based detox benefit. There is no residential treatment for Medicare recipients currently in any Medicare program in the United States. None. If you have Medicare benefits, you do not have access to ongoing residential care or rehab services, as it's typically called. So parity will go a long way to making sure that those folks have access to care. That said, the one final thing that several of us here have been talking about today, and I will have to miss the next, at least the part of the next 2-day conference on this issue, because there is a huge rally, actually, in Washington, D.C. this Sunday. It's called the Unite Against Addiction Rally. There are going to be several thousand people from all over the United States demonstrating about access to addiction services. I will be there. Many people who are here today plan to be there. We hope it's a huge rally that gets a lot of national attention. It will be a live broadcast on the web. So if you go to uniteagainstaddiction.com, you can actually see the rally if it doesn't make the national news. And we're hoping that we can actually impact public policy, funding, and other things that will make addiction treatment more accessible for everybody. So thank you.